Hello, and welcome to the Department of Respiratory Medicine Linear Endobronchial Ultrasound Service. This next case is a 74-year-old lady with a number of comorbidities, including prediabetes, paroxysmal atrial fibrillation, hypertension, and gold stage 1 COPD. She has an excellent performance status, and up until Christmas was well. She had an elective laparoscopic cholecystectomy in early January and declined in terms of symptoms from there on in. Initially, it was felt to be a complication of her surgical procedure, but unfortunately, staging protocol CT chest, which was performed 2 weeks ago, has identified a subcarinal mass, which we suspect to be carcinoma. This next case is a diagnostic procedure only. So I'm sitting in the trachea here, roughly about the third ring interspace. And 90 degrees clockwise rotation will take me very nicely into the right main bronchus. And immediately in view is the right upper lobe. And if you place the linear ultrasound probe on the mucosal wall just underneath the right upper lobe, that is station 11R.
Are you happy with the depth?
Absolutely fine with the depth. And there is an enlarged circular lymph node in station 11R, in fact, several.
So one node,
yeah.
Perhaps another here.
Yeah.
So okay, this is 11R.
This is 11R.
Okay.
So I'm now going to...
okay, I'll take that off now.
Pull the scope out slowly and reoppose the ultrasound probe just proximal to the right upper lobe orifice.
Now we've got another structure coming in here.
Well, I'll take you through what they are once we've got a slightly better ultrasound image. So here's the SVC, and I'm just going to advance the scope slightly further down the trachea, and what I'm looking for is the azygos vein, which actually
I think go down a little bit.
There.
Yeah, it's there. Yeah.
So we have SVC here, and then just here.
Yeah.
Okay. Can you tell me what movements you're doing to be able to achieve that?
So literally it's about 10 degrees clockwise rotation, very slowly.
Clockwise torque.
There we are.
Beautiful image. Beautiful. Okay, so this is the azygos vein coming off the SVC, or joining the SVC, as it were.
So there's there's a small 10R lymph node at the top there, which is
just here,
which is distal to the azygos vein.
And this is our scale here, so that makes that node officially
about 5 millimeters.
Small. Okay,
but it's round.
But it's rounded.
Yeah.
So it shouldn't be there. It should probably.
Correct.
Okay.
And then there are nodes proximal to the azygos vein. In station 4R territory.
So in your opinion, does this look pathological as well?
Well, there are features of the lymph node that concern me a little bit. The shape is eccentric. I think it's heterogeneous. There's no obvious central hilum.
Can you allow me to freeze this for a second? So in terms of, so you're describing the elliptoid, I guess, the structure, and then the center,
the echo architecture.
The size, I guess, if we're going in the short axis,
probably just under a centimetre.
Probably just under 10, so maybe 8 millimetres in cross section.
Yep.
Okay. Very, very nicely done.
Okay, so now I'm now going to keep in my hand position exactly as it is.
Yep.
I'm going to slowly pull the scope upwards.
So we're ascending the trachea.
Correct. Keeping the SVC in view as best you can. And coming into view at the top is an artery. That's the innominate or brachiocephalic artery.
Right.
Now, I'm going to track this over to the left-hand side in the following way.
Sorry, there is just underneath that brachiocephalic artery, there is a small 2R.
Here?
No, no. Yeah, just there. Yeah,
This one here.
yeah.
So that is a 2R node.
So this is superior, this is inferior.
Yep.
So this is the structure. So this is inferior to the brachiocephalic or innominate artery.
So
I've got you.
So to track this, you actually rotate your hand anti-clockwise, very gently,
Wow.
and follow the scope. And I'm now moving the scope back down the trachea.
Yep.
Now what I'm looking for are 2L nodes, and there is actually a 2L node just nestling in there at the top.
Here.
Yep.
Yeah.
Here.
Yep.
Here.
And we can just see the ingress of the brachiocephalic, or the egress of the brachiocephalic artery from the aortic arch. And in fact, you've got two
There's
arteries,
common
very nicely shown there.
So the
On
first
top
one.
is the innominate or brachiocephalic artery, and below is the left common carotid.
Wow.
And that is the aortic arch.
Oh, right, yeah. Doing very well.
She is sensitive on the left.
I think, yeah, every time you go there. Oh, right there. Okay, we're going to do a little bit of suctioning.
She's actually bleeding from the left.
So it's very friable.
Yeah. Just in the aortopulmonary window there. And there are some small nodes in station 4L.
So left pulmonary artery,
but I-
aorta.
Yeah.
But I don't want to stay there
Yeah.
too long because it's
irritating
irritating
it.
to her.
Okay.
And then we should say something at station 7.
Okay, so where I'm really interested is station
Wow.
7, and we got a
Stand at
huge
22, please.
heterogeneous structure measuring in excess of 5 centimeters.
This is
Yeah.
very large indeed, and it's very irregular.
Yeah. Now there are areas of central necrosis. It's lobulated. There's no central hilum, and I would grade this as almost certainly
Malignant.
yes.
We're not getting
Will you
any
permit me to freeze this image for a second?
Yep, we can label it perhaps.
So this is going to be a.
Sorry, just
going to give a
sorry.
little bit
missed
more
it, so,
sedation here.
Is that freeze?
Yep.
Should be able to scroll.
So yes. So if you
if I just
bring
hold
it
it
back in, to just get a couple of seconds of image. So what I was hoping to do was to highlight. Can I stop it? Freeze it there.
Yep.
So if we just go back here, then we have a very, very irregular edge. You can see that this is almost extending out over here and here. This is a very, very sinister pathological node.
And there are areas of
There are
central
areas
necrosis.
of central necrosis here and here, possibly down here and here, and maybe there as well. So these are areas where if we put our needle into, then we're likely to get dead tissue or tissue that's not going to be as helpful. So this is station 7. So if I call this station 7 here.
Okay.
Okay, we'll go for a biopsy.
Now again, because with the size dimensions, you've sized and locked it to about
Well, to be honest,
4
this
centimeters.
this lymph node is
so big.
It's so big. It's actually bigger
so
than
big.
the maximum
extent
length
of
of
the
the
needle.
needle.
Yes.
The maximum throw of the needle. Okay.
The first angle.
So we have needle coming in here,
And just to show that actually
and
five
the
degrees
extent of it is actually all the way down here.
5 degrees rotation, and you lose the needle.
Yeah.
And the idea is to keep that needle in view.
So this is the portion that we must be able to keep when we're going down. Yeah. So this is a nice demonstration of multiple agitations in a single plane.
Yeah.
So that's a little bit of air there. That's the needle tip there.
That is, ladies.
And remind me the vessel that's underneath us.
There's going to be
Aortic arch, perhaps?
no,
it's going to be
I think it's probably
left atrium.
left atrium.
Left atrium.
Yeah.
all right. Yeah. Doing very well. Secretion, please.
So that's your first pass.
Look at that for you can see the air artifact where the needle's been.
This is the air artifact here as the longitudinal line.
Yes.
That's quite a good guide as to where you might want to go next time,
absolutely.
So I'm just
depending on the feedback from rapid on-site evaluation, I guess.
Indeed.
And this is an example where one node is coalescing into another.
And do you see they look different?
They do. They are certainly different, aren't they? That's probably the cutoff of the node there, but it's definitely extending into it.
So the architecture of that more distal nodal structure is different. It looks more it looks denser. We could use tissue elastography to demonstrate that. But we'll see what
the depth, the frequency of the megahertz.
Okay. Andy, you're
6.
come gently up. Gently up.
All right, sorry.
Sorry. Yep.
Sorry, can you keep us in view?
I beg your pardon. Yep.
Yeah.
So we're just beyond there.
That's all right. I think it's okay there.
It's actually safe there, isn't it?
Yeah.
There's just some adventitia below it. So as soon as you switch the vacuum on, we should be able to see telltale signs. There we are, telltale signs of material going up in the vacuum.
Yeah. Someone needs to explain the physics of that to me. But
now, do you have any advice for a trainee who's doing their first FNA and standing where you would be standing, Raoul?
Yeah.
Because obviously you are an expert in this. Do you have any advice about how fast to do it?
Well, I think
as part of the learning curve.
I think the first thing to do is probably do it with both hands, so you have a better control.
Okay.
And in the initial stages, the key thing is you should never come out of the node accidentally.
Okay. So always stay within the boundary of the node from here to here. Is that correct?
Absolutely.
Okay.
And it has to be gentle when you're learning, and as you get more experience, then the speed can go up. Okay. I don't think there is any evidence to suggest speed has anything to do with the material whatsoever.
No
one's looked at it.
And also, one of the the key reason why you shouldn't come out accidentally is because then it gets contaminated.
Contamination.
Yeah.
Okay, so the first pass is scanty but diagnostic.
All right, yeah. Okay, we're just going to do a little bit of suction. You've got some secretions at the back of your throat.
So from I'm just hearing from the pathology team that pass 1 was diagnostic. So we won't be making any more slides, and all the material will go straight for cell block.
Can we get some local, please? Is it here? I'll get it.
Thank you, sir.
All right, yeah. Just putting some more local anesthetic. It will settle down. Give it about another half a minute or so. Okay, you're doing really well. We're getting some good samples. Hopefully it shouldn't take too long now. Give us another 3 to 5 minutes.
So this is pass number
3.
3. And again, same area, station 7.
Yes.
Subcarinal node. So the needle is coming in through here.
Lovely.
Very, very nice. Right, stays right within the node.
Yes.
And then you're expelling the contents.
That's the movement of the stylet in and out.
Yep. As the stylet comes out, you can actually see material tracking up, following behind the stylet.
So it's capillary action, isn't it?
Capillary action. And there is a substantial body of literature in the EUS world about getting tissue acquisition just with the stylet retraction alone.
I think the same applies for EBUS as well.
Yeah.
So there are certain centers, what they do is just very slowly and gently pull the stylet out, and they do not apply any suction needle, suction syringe.
Tony,
Yeah.
in terms of amounts that we've got,
Yeah.
just I'm not sure that we'll have a long window with this case to do much more. So
Yeah.
what have we got?
Sedation-wise?
It would be, well, more is always better. We'll see what we get from this. If you can do one more after this, then that might do it.
Yeah.
Okay.
Okay, I think that's fair.
Sedation-wise, how much is
She said 2 milligrams of midazolam
200.
and 200 micrograms of
alfentanil.
So there are some worms.
So there are some microcores
Yes.
Yes.
for histopathological assessment.
Yeah,
Okay.
indeed.
And do those microcores go directly into
Formalin.
formalin?
Yes.
Okay. So I guess the beauty with rapid on-site evaluation is you get your cake and eat it. You get your slides for cytology, you get some material for cytoblock,
Yeah.
and you get the microcores for histopathology.
Yeah.
Indeed.
Okay.
And because they know from the Rose slides
Yep.
that this is mitotic.
We've already got it. So any other material is surplus. So
And
for your
they speed up the process. So
Yeah.
they will start analyzing as soon as they go back to the laboratory.
and for your cytoblock, you can use that material for molecular markers.
Oh, yeah,
yes,
yeah,
yes.
yeah. That's the whole point, really, yeah.
Yeah. Okay.
What was that last pass like, Tony?
Decent, yeah. Yeah, volumes, yeah.
So if this one's okay, we'll make this the last one.
Okay.
Yeah.
Give me one more minute.
Yeah. There's
This
some
is
reasonable
Bernal.
worms as well.
Gently up a little bit.
That's okay.
Yep.
Nice. So I noticed that every time you do a pass, you're selecting a different area of the node,
Yeah.
which I guess makes sense because
Most
it's not going
deliberate.
to be contaminated by previous blood or
Yeah, exactly.
needle track.
I mean, sometimes you're not afforded that privilege when the target
Right.
isn't very big, but in this case, it is. So you've got opportunity to assay from various different parts of the nodal structure.
When you're towards the end, can we take one still image? Can you let me know when you're about to stop?
Yeah.
Okay, I'm just going to take a still image there. So just hold on there. Okay, and then
Station 7.
so station 7, and I'll just measure this. Oops, so this is station 7, and then we'll capture another still image. And this is the final thing. This is the FNA needle.
Hey, sorry, the
oops,
needle's,
yeah, we need
the
to-
needle's sitting in there at the moment.
Yeah. Okay. Okay. Well, I'll leave that. We'll go for that, and then we'll
Yeah.
come back out. Okay. And can I just make this a little bit bigger?
If you freeze that, you can go back.
Yep. Happy?
Mhm.
These are
Keep
beautiful images.
Keep scrolling and you'll get to the point of the needle. There are, it's coming now.
Okay, so that's good, and then we'll capture that.
Okay, and just for the benefits of the trainees watching, if you can,
Nearly done, nearly done. We're just checking that we got enough sample and we'll call it a day.
make sure there's no active bleeding.
Okay.
Not much.
Hello, my name's Andy Barlow. I'm one of the respiratory consultants here at West Hertfordshire Hospital's NHS Trust. The point of making this short video here is to demonstrate that this is absolutely a team effort. A complex endoscopy requires everybody to play their part. So I'd like to first of all thank the endoscopy nurse team who are scattered around here in the audience. I'd like to introduce the pathology team.
Hello, I'm Winnie Tang. I'm one of the senior biomedical scientists. I make the slides for the pathologists to look at.
And I'm Dr. Tony Maddox, and I'm the pathologist that she makes the slides for.
I'd like to thank my endoscopy colleagues.
Ray McCrudden, gastroenterologist from the Royal Bournemouth Hospital. I do endoscopic ultrasounds, not EBUS, but I'm very flattered and grateful to be asked to be part of the teaching and training today.
And
thank you. I'm Rahul Mughal, one of the chest physicians, works at Watford General Hospital, West Hertfordshire Hospital's NHS Trust, and as my colleague Dr. Barlow mentioned, this wouldn't have been possible without the teamwork, and that involves endoscopy staff as well as pathology and Dr. McCrudden coming all the way from Southampton. Thank you. Bournemouth, sorry.
So once again, a final thank you to everybody for a fantastic day, and let's look forward to the next training video.